That applause was as much for James' eyes as it was for him himself. That's fantastic. All right, if we could just have my slides up, please. So having gone through the definition, the basic diagnosis of the different types of dry that may be available, now we've gone through that diagnostic process. And at this stage, you should have some idea of A, whether the patient has a dry eye or not, and then secondly, the relative composition of that dry eye in terms of evaporative versus aqueous deficient. How do you then manage it? And that was really the role of the management and therapy report. So I was very privileged to be able to be the chair of this subcommittee. Our subcommittee consisted of 15 subcommittee members from 10 countries. We actually covered 7 different languages, and it was only 7, only if you bucket together US, Australia, Canada, and New Zealand, and of course that's arguable whether we actually all speak the same language. So this group of people were charged with basically looking at the available evidence in terms of how do we as clinicians then manage patients with dry eye. So we really had 2 functions. The first function for our committee was to conduct an evidence-based review of current dry eye therapies and management options. And by evidence-based review, we really did look into the peer-reviewed literature where possible. If there was any evidence that was relatively new that only existed in the form of abstracts, we used that, but by and large it related to peer-published publications. Once we'd done that, the second role of our subcommittee, which was actually far more complicated, was to then use those results to produce, if you like, a staged management algorithm. You'll see from the last slide that James had up that we developed these basically into 4 different steps, and I'll present that at the end of this section. But basically what we wanted to do was to basically come up with some form of stepwise approach to implementing all of these potential management options to be able to manage the disease according to the disease severity. So if you can subdivide the dry eye disease into various subcategories, both whether it was related to aqueous deficient or evaporative, and then also the severity of it, could we apply the evidence that we have on those management and therapy options to come up with a management plan? So those are the 2 things we needed to do. In terms of the evidence that was available, it's very important when you review the peer-reviewed literature to actually look at the level of that evidence. How really well conducted was that study? And so we subdivided up the clinical studies and the basic science studies into 3 levels of evidence, where level 1 evidence was the highest level of support and showed, for example, under the clinical studies, at least 1 randomized controlled clinical trial, which was very well conducted, and the same for basic science. So we subdivided up all of these papers that we looked at into 3 levels of evidence, where level 3 would be, broadly speaking, more of an uncontrolled clinical trial, maybe a case report. The most significant challenge that we had as a committee as we went through this process was the incredible explosion of studies and areas to consider compared with a decade ago when the first DEWS management and therapy report was published. That report was 16 pages long, had 4 tables and 185 references. This one, not so much. This is a monster. It's 55 pages long, 16 tables, over 1,000 references, of which 73% actually were conducted since that report over a decade ago. So it is a very interesting read, certainly for those of you who require help sleeping. And the challenge I've now got is I've got about 15 minutes to cover all of this stuff. Not possible. I speak pretty quickly, but not possible to cover that much. So what I'm really going to do is kind of more cover what's in the report in terms of what you're likely to see when you open it up. We basically ended up subdividing our results into 7 areas. The first area of which was treatments for tear insufficiency. This is basically one that we're very well versed with as clinicians. And these treatments for tear insufficiency, we subdivided up into 3 separate areas. We subdivided up into those relating to tear replacement, tear conservation, and then finally tear stimulation. Let's start by looking at the tear replacement section first of all. And of course that was a fairly major section because that related to ocular lubricants. And this is really the mainstay of treatment. Within the ocular lubricants, we subdivided that up into 7 separate sections. So we looked at things like the impact of various viscosity enhancing agents, things like osmotic agents and osmoprotectants, the impact of antioxidants, preservatives, what the function of inactives were and what evidence there was to show that that made a difference, and then finally some of the newer information looking at lipid-containing drops. Obviously a big section, as you would expect, related to ocular lubricants, and as I said, this still very much is a mainstay of therapy, particularly in the early stages of the management of dry eye disease, and obviously there are incredible numbers of topical formulation available. One of the things that became very obvious as we went through this was that it is very important, particularly in severe dry eye, to avoid preservatives, and that's actually covered both in the iatrogenic report as well as in our management and therapy report. But interestingly, when we reviewed the literature, there's actually very, very few well-conducted studies, very few randomized controlled trials actually comparing the relative superiority of a particular over-the-counter product compared with others. And that's certainly an area that we need to do better on moving forward. There's also a section in this section on biological tear substitutes. We're increasingly becoming aware of the importance of things like autologous serum, particularly in more severe disease, and there's a very nice review overlooking these biological tear substitutes. What was very obvious is that the reports generally are positive, but the problem comparing one study to another is that each preparation, depending upon who it is that compounds it for you, which hospital or which pharmacy does it for you, ends up basically having a various different ways of producing it. And so it's very difficult to tell whether this formulation is truly better than another because of the non-standardized way of doing that. And so again, that's something that I think we need to do moving forward. The next section really dealt with looking at tear conservation. This was subdivided into 3 groups: punctal occlusion, and of course, interestingly, many of us are very comfortable doing that with plugs, either with temporary plugs or permanent plugs. But again, very interesting that there are no and 0 level 1 studies. So it's very difficult to do a truly randomized controlled trial because you end up having to do sham treatments where you persuade patients that you've actually done occlusion when you're not really doing it. Otherwise, there's always the potential placebo effect. We looked at both absorbable and non-absorbable or permanent plugs. And the conclusion that we came to is that there is a lot of evidence out there that it works, but it appears to be most successful when combined with other treatments. Rarely would you do that without doing other treatments as well. We then moved on to looking at what happens if you permanently occlude the puncta, and then finally looked at things like moisture chamber spectacles and humidifiers, and again found that really there is very poor evidence to show that they work. And in those studies that are supportive of those moisture chamber spectacles and humidifiers, most of them again are relatively low levels of evidence. After that, we went on to looking at tear stimulation. Really covered 2 areas, secretagogues and then a new nasal neurostimulation method. The secretagogues, we looked at both topical and oral secretagogues. When it comes to topical secretagogues, there are a number of formulations now commercially available around the world, but interestingly, none of them have passed muster to be able to obtain clearance to be used either in North America or in Europe. Most of these are available in Asia. Also, there are some oral secretagogues that are used in very severe forms of dry eye, typically Sjogren's syndrome, but again, the evidence that's out there at the moment seems to support their use in the management of oral dryness as opposed to ocular dryness. The final section within here was, as I say, to look at a new nasal neurostimulation method. Allergan have recently achieved FDA approval for the use of a device that basically it basically has 2 prongs. You stick it up your nose and it nasally neurostimulates your nose. That produces basically a temporary increase in tear production in adult patients. So again, that's recently achieved FDA approval, and I know is looking to seek European approval at the moment. We then moved on to treatments for lid abnormalities, much of which Jennifer's talked about here and also will address in her keynote presentation later on this afternoon. We subdivided that into looking at management of anterior blepharitis, Meibomian gland dysfunction, and a variety of blinking abnormalities and exposure. Within this, the most relevant, of course, was lid hygiene, which again, many of us are very comfortable prescribing to our patients. Lid scrubs, again, very interesting. There are, of course, no universal guidelines, and interestingly, again, no level 1 studies. We have no high-level evidence of how it is that lid scrubs are successful in clinical practice. Large section then on warm compresses, of which we cover pretty much anything that is commercially available. And finally, we look at the more recent discussion around the management of Demodex using both tea tree oil and ivermectin, and again, a significant amount of evidence that would support the fact that tea tree oil is particularly useful in the management of Demodex, and that's very well described in the report. When it comes to blinking and lid abnormalities, really this covers a wide variety of often difficult to manage variations on corneal exposure. When it comes to treatments for these corneal exposure, really you're looking at essentially 2 different types of management. The first are barriers, so things like tear supplements, ointments, moisture goggles, and then also contact lenses. Growing evidence to show that things like soft bandage lenses, and in particular scleral lenses, can be very valuable in managing these very difficult to manage patients. But again, at this moment in time, when you look at the evidence, really only level 3 evidence, so relatively poor levels of evidence, and we certainly can do better in terms of conducting clinical studies on these managements for blinking and lid abnormalities. We then moved on to looking at things like Meibomian gland dysfunction. Again, Jennifer will talk about that a lot this afternoon. Ocular lubricants containing lipids, a growing evidence of their value, and also physical expression and unplugging. So this is not the diagnostic expression that we just showed, which is to basically help us diagnose dry eye. This is therapeutic expression in terms of being able to physically unplug those glands and get them working in. So the kind of thing that we would now look to do with James to actually manage his evaporative dry eye. And again, more and more evidence to show how important this is in the management of dry eye in many, many of our patients in clinical practice. We then moved on to anti-inflammatory therapy. We now have growing acceptance of the fact that many cases of dry eye have a sub-inflammation going on. And so how is it that we manage inflammation on the ocular surface? Well, of course, one way of managing inflammation is to use topical steroids. And again, we found 9 randomized controlled clinical trials showing that in severe cases of dry eye, or indeed in moderate to severe dry eye, it can be very useful to actually use steroids to kickstart the management of these patients, where often we will get it under control and then move maybe to other forms of management later on. Because the problem with prescribing topical steroids, of course, on a long-term and ongoing basis is that we know we have the risks of IOP, increases, cataracts, and also infection. So yes, good in the short term, not good in the long term. How else can we manage inflammation? Well, again, we have new drugs coming along. Recent clearance in the US and Canada for things like this LFA1 antagonist, so lifitegrast, has now been approved for management of subclinical inflammation, and also, again, lots of evidence to show that a wide variety of systemic and topical antibiotics can be very useful for managing this ocular surface inflammation. Nice section written on surgical approaches. Probably, I think, the best section that's ever looked at using these often heroic measures to control very often very severe dry eye. So things like tarsorrhaphy and often things like conjunctival surgery, and even the production of things like mechanical Dacryo reservoirs. These are very complex, fairly late-stage managements, but again, at the moment, nowhere has really analysed this in great detail, and that's actually very nicely, I think, done in our report. We also looked at dietary modifications. Again, growing evidence to show that just by simply giving dietary advice to our patients can actually have a relatively important function in terms of controlling and managing dry eye. Things like general hydration, so taking on board lots of water. We did look for studies as to whether taking on board alcohol as replacement for water would work. We couldn't find those, but we're still looking. We've actually been doing a study here this weekend to see if we thought this would be a good audience to test that out. In fact, most of the evidence would seem to suggest that alcohol does quite the reverse, as many of you have the tongue stuck to the roof of your mouth this morning will remember from last night. Very nice section written on essential fatty acids. Huge amounts of evidence now coming to the fore about the role of things like omega-3 supplements. And again, this is very nicely detailed in our report. And even things like antioxidants and calorie restriction. Again, pretty good evidence to show that by giving this kind of advice can be very useful in the management of dry eye. The next section we looked at was local environmental considerations. So again, just thinking about the environment in which the patient lives and works. What very simple measures can we suggest? This has a lot of close link with actually the iatrogenic report. But again, some very simple things that we can think of as practitioners to prescribe to our patients, which will help control their dry eye. And then the final section we looked at, the seventh section, was again a brand new section which certainly wasn't in the first report 10 years ago. But again, now some pretty good evidence to show that complementary medicines, things like herbal and natural products, honey, even milk, and things like acupuncture can actually work very helpfully in terms of the management of patients with fairly significant dry eye. So those were the sections that get covered in terms of what available evidence do we have to manage dry eye. We then had to take all of that evidence and try to come up with a treatment algorithm. And of course, this is very often for us as clinicians the kind of main takeaway. Yeah, sure, we've got all that stuff, I believe you, but what am I going to do tomorrow? I've got this patient come in, I've done all of my diagnostic tests, I know they've got dry eye, how am I going to manage it? So this is basically what the link on directly from the section that we've just had James describe, which is the diagnostic report. We then subdivided all of those managements into effectively 4 steps. So step 1 being something that you would do early on in the disease process, step 4 being something that you would do with more severe dry eye. And as you'll see here, one of the things that we were particularly interested in trying to get to grips with was if we look at those with evaporative dry eye versus those with aqueous deficient, many patients will have mixed disease. So in those patients, taking into consideration what type of dry eye they've got and how severe it is, how do we come up with a prescription, if you like, for managing that patient's dry eye? And that was probably the biggest challenge that we had. I know you're not going to be able to read this. It's not intended to. That means you'll have to read the report when it comes out. But in trying to come up with where each of the management therapies come into, it took us a little while to actually argue about which step they go into. But the major thing that we struggled with was trying to take that evidence and say, if you've got a patient who's got solely aqueous deficient dry eye, this is the best management. If you've got a patient who's got solely evaporative, this is the best management. And the reason that we struggled is because that evidence isn't there. When we think about how we diagnose dry eye, we're kind of early in the process in terms of thinking about that diagnosis being aqueous deficient, evaporative, or mixed. And as a result, the studies haven't been conducted to then tie those to a management. And so that, I think, is going to be one of the biggest areas that comes as a spin-off of this report, is generating that evidence. When we know what type of dry eye that we have, what management is best to prescribe. And so at the moment, that evidence doesn't exist. We've done the best that we can in terms of trying to provide some advice. So here's basically what we came up with. It's a 4-step process. It's not a rigid stepwise process. It may be that you end up with a patient who ends up with some step 2, and maybe you bring in something from step 3 at that same time. So it's not meant to be a rigid stepwise process, but basically we, as you'd imagine, as we as clinicians do every day, you begin with more simple therapies, and then of course progress through to the more complex, and options within each category that we list certainly not ranked according to their importance. We just were able to rank them in terms of, we think for this severity of dry eye disease, this is where this management probably ends up being most valuable. And so that was basically what we ended up doing. Say 2 phases to the report. First phase, huge amounts of evidence for you to read and see how much truth there is out there about the fact that all of these management therapies actually work. And then the final section really relating to this stage management algorithm. With that, I'd like to thank again all of the sponsors for TFOS Dues 2. These guys put up a huge amount of money for this multi-year process, and I'll thank you for your attention. Thanks very much.